All right, good morning and welcome to the Department of Medicine grand rounds for this finally what appears like spring morning. Today we have two highly talented speakers who are going to talk to us about central nervous system vasculitis. And I was very intrigued last week when I was at the Boris Clinic seeing both neurology and rheumatology faculty functioning together in a combined clinic dealing with CNS vasculitis was really fantastic. So our speakers are Dr. Kim Legault, and Kim is Associate Professor of Medicine in the Division of Rheumatology here at McMaster, and she's a Program Director of Rheumatology Residency Training Program. She's the co-chair of the Medical Subspecialty Program Director Committee. Kim has completed her medicine and rheumatology training here at McMaster and has master's in health research methodology. She has clinical and research interest in connective tissue disease, particularly SLE and antiphospholipid syndrome, and in patients with inflammatory neurological disorders. Sashi Perera is our other speaker. Dr. Perera is an investigator in the Brain Health Research Program at PHRI, an Associate Professor of Medicine in Neurology at McMaster University, and a stroke neurologist at the Hamilton Health Sciences, attending at the stroke clinic and the stroke unit. Her main research is focused on secondary stroke prevention, cryptogenic stroke, and uncommon causes of stroke, and optimization of clinical care in these populations. She has served as a principal investigator and co-investigator for phase 2 and phase 3 clinical trials, and is on the adjudication committees for international multi-center stroke and cardiovascular trials, and she has won research awards and has published her work in high-impact medical journals. Can't say, enough about those highly talented speakers today, and I'm actually from the attendance, and I myself is excited to hear about this. So without further ado, I'm just going to pass it on to Dr. Perera and Dr. Legault.
Thank you very much, Dr. Azam. Thanks to everybody for attending, and we always like to speak about this topic, which is near and dear to our hearts. As you know, we do run as you heard, we do run a neuroRheum clinic where we see inflammatory brain disease such as primary angiitis of the CNS, and we're going to be focusing predominantly on that primary disorder. But to figure out if one has primary angiitis of the CNS, one needs to consider many different types of disorders. So we will delve into a bunch of different things today. We want to start by saying that we're privileged to provide care on lands that Indigenous peoples have called home for thousands of years, and we acknowledge that we meet on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. So we don't have any specific disclosures pertaining to this talk, but first we are going to be talking about entirely off-label medications. As one would imagine, people aren't banging down the door to get on-label indications for primary angiitis of the CNS at this time, maybe in the future. So everything is off-label, and we do run a combined neuroRheum clinic, which is a disclosure that we, sort of have, a vested interest in these things.
Okay, great. So to start off with, I wanted to just go over a day in our neuroRheum clinic, and the question that we get always is, does this patient have CNS vasculitis? They could have many other problems, but is this affecting CNS, the brain too? And I'll go over a few referrals we get. This is a typical day in our neuroRheum clinic. So we have a 66-year-old with hypertension and dyslipidemia and diabetes, well controlled, but presents with some balance issues and visual disturbances. The referrer says the CRP and vasculitis screen is normal. MRI shows a left MCA stroke, white matter hyperintensities are there. That could be age-related, maybe a little bit too much for age. And then he's also had a CTA, which shows diffuse narrowing of the intracranial blood vessels. And it says likely, given his age and vascular risk factors, likely secondary to atherosclerosis, but vasculitis cannot be ruled out. So how do we decide that this is vasculitis or just athero-related? And then a second patient is a younger patient, a 27-year-old with right-sided weakness and an episode of vertigo 6 months ago, and then which lasted for about a month, and an episode beforehand about a year ago with bilateral leg weakness. And again, lasted a few days, didn't really seek much medical attention, just went to the family doctor. And in between, he got COVID too. So thought maybe the weakness was related to that. And again, his ESR and CRP is normal, and MRI shows multiple lesions consistent with demyelination. And it says meets criteria for dissemination in space and time. So the criteria is the multiple sclerosis criteria, the McDonald's criteria. And you have to remember that MRIs are not specific for multiple sclerosis. Any inflammation could look like multiple sclerosis, and his CTA is normal. And then another case that's been referred would be a 56-year-old with a 30-pack smoking history, sudden onset memory difficulties and mild headache for about 1 month. And the memory difficulties are in the form of global memory deficits. That's very uncharacteristic for him. CRP, ESR, and vasculitis screen in him is also negative, and his MRI actually has bihemispheric stroke, both in the anterior and posterior circulation, with some white matter hyperintensities. And CTA shows mild atherosclerotic plaque in cavernous ICA, but no other significant changes. So between these three, does all these three patients have vasculitis, or how do we decide which one, and how would we investigate? And we'll go over step by step and hopefully give you approach to these patients' diagnosis at the end of our talk. So objectives for today would be to when and how to investigate for CNS vasculitis, and we'll go over some common pitfalls and mimickers of CNS vasculitis, and also then at the end go over treatment options for CNS vasculitis. Over to you, Kim.
So what CNS vasculitis is inflammation of blood vessel within the walls of the blood vessel, in the brain and the spinal cord. And so there's inflammation that we actually see within the wall. There's fibrinoid necrosis of the wall. And what that leads to is a variety of different potential pathologies depending on the size of the vessel and what exactly goes on at that current time. So particularly in small vessels, you get narrowing of the lumen due to thickening of the wall that can lead to stenosis and ultimately occlusion from that mechanism. Or there can be a hypercoagulable state that's produced locally within the wall, and then an acute thrombosis of that particular vessel. And then especially in larger vessels, if there's focal lesions within a larger vessel wall, there can be development of aneurysms in the wall, and then subsequent rupture leading to potential bleeding. So there's both stenosis and potentially aneurysmal dilation of the blood vessels. So the CNS vasculitis classification / causes of secondary vasculitis sort of is as follows, and these are things that we consider for every single patient that we are called about for these things. So primary CNS vasculitis is only one and a very rare subtype here, whereas secondary vasculitis, as you can see, has a wide differential. And there's a variety of different mechanisms whereby these entities cause secondary vasculitis. Sometimes it's as a secondary immunological phenomenon. I mean, there are some viruses, for example, hepatitis C being an example, where one can get inflammatory phenomenon in a variety of different organs, kidneys, in nerves, and then then in brain as sort of an inflammatory phenomenon, and some of them are actually like angioinvasive. For example, like some fungi would be angioinvasive, where they are actually causing inflammation of the wall due to direct invasion. So there are a variety of different etiologies for these things, but they will look very similar on imaging and sort of on our standard, especially our non-invasive tests for it. So if we go just through this differential, then we talk first about the infectious categories, and we've had some viruses recently that have presented with stroke in our patients on recent weeks on the stroke ward. For example, VZV, we've had a case of that. We've had an HSV within recent months that led to a secondary CNS vasculitis and stroke. So that you can see CMV, HIV, the hepatitis B and C, and then tuberculosis being another infective endocarditis. All these can lead to a secondary CNS vasculitis. Drugs can give a vasculitis or a vasculitic appearance, some of them being, again, actually causing a vasculitis as an inflammatory phenomenon, like cocaine that can give some sort of can stimulate inflammatory pathologies, and some that give vasoconstriction and can look very similar, such as some pathomimetics and amphetamines, things like that. And then the vasculitis secondary to systemic disease, the connective tissue diseases can have sort of a vasculitis. Often it's like more of a perivasculitis on biopsy, and there's probably some other parenchymal inflammatory brain disease targets in that group, but they can look, again, very similar and can give inflammatory sort of pathologies and presentations that are similar to CNS vasculitis. So this is the group, of course, where the rheumatologists kind of jump in and look for connective tissue disease, rheumatoid arthritis, the scleroderma. We've had a recent case of a patient with scleroderma and inflammatory brain disease. So there's a variety of different ones, and then ulcerative colitis and even celiac disease have been associated. Malignancies are another ones, especially lymphoproliferative disorders, which can absolutely give a similar appearance, and even to some degree some vessel wall inflammation secondary to those, and they can really mimic a lot of different things. And then primary systemic vasculitis. So again, the group, the ANCA-associated vasculitis, where they have evidence of ANCA vasculitis other places, and then there's also brain involvement, Behçet's, et cetera. So I think our next slide will go a little bit into that. Everybody's sort of seen this slide where there's the large vessel, medium vessel, small vessel vasculitides, and all of these can have CNS involvement. So large vessel involvement, for example, giant cell arteritis sometimes affects the posterior circulation vessels, and then you can get stroke related to that, all down to the small vessel secondary to ANCA vasculitis. So any of these can be a cause of vasculitis in the brain as well. So primary angiitis of the CNS specifically is an inflammatory disorder of the blood vessels of the brain and the spinal cord, but without any evidence of systemic vasculitis elsewhere. It is quite rare. 2.4 cases per 1 million patient years is the kind of statistic that's come out, though of course it's very difficult to study this entity, and many might go unnoticed depending on the pathology. There does seem to be a bit of a male predominance, and it is something that affects young people. So the median age at diagnosis in the cohorts is sort of late 40s, early 50s. And then the PACNS proposed diagnostic criteria back from 1987 is the presence of an acquired and otherwise unexplained neurologic deficit with presence of either classic angiographic or histopathologic features of angiitis within the CNS, and no evidence of systemic vasculitis or any condition that could otherwise elicit it. And of course, that last one is the big caveat where we have to rule everything else out. And I probably all the residents on the stroke ward are tired of hearing me say this, because I'm always like, when you see something that looks like CNS vasculitis, you're not like turning your brain off and saying CNS vasculitis. You're now going through that whole differential and ruling everything out. It's kind of like heart failure. It becomes this syndrome that then you have to explain, okay, why is the heart failing? Why are the brain vessels failing? Why are the brain vessels inflamed? And so we have this large differential that we have to go through. Over to you.
Thanks. So I'll go over clinical features, laboratory features, and CSF findings and neuroimaging. And as we go over, you'll see, like, unfortunately, we don't have one biomarker that clinches the diagnosis, but there's a constellation of symptoms and all the laboratory features that we can put together to come to a diagnosis. So primary CNS vasculitis usually has an insidious onset and is slowly progressive. Diagnosis usually take about 6 months in 75% of cases. Sometimes it could be delayed for at least 3 years just because of the insidious onset. And if you don't have high suspicion, you could miss it. And headache is one of the most common features. They are usually a low-grade grumbling headache, could be generalized or localized, slowly worsening, and there could be periods that spontaneously, like the patients will have no headaches. They could have 3 months history of headache and then no headaches for about 2 months, and they start again. And one thing to remember is a thunderclap headache, a headache that the worst headache of your life, that is 10 out of 10, reaches maximum intensity in 1 minute. That type of a headache is not a characteristic of CNS vasculitis. Why this is important is one of the differential is RCVS, like reversible vasoconstrictive syndrome, that has a typical feature of thunderclap headaches. But the imaging features are very similar to primary CNS vasculitis. So if we, if you get the history of thunderclap headache, you have to question, like, is this really CNS vasculitis? And in cognitive impairment and behavioral changes are common. About half of these patients would have this. And stroke, and they can present acutely with stroke or TIAs, and about that also happen in about half. And constitutional symptoms are uncommon. About 10%, less than 10% could have fever and weight loss. But as soon as someone has that, you have to think of other diagnoses. You can't jump to primary CNS vasculitis, even though everything else fits. And then laboratory findings, again, CRP and ESR are usually normal, but they could be elevated. Like constitutional symptoms, if they are elevated, you have to think of other diagnoses. Like, we are talking about primary CNS vasculitis, like it could be elevated in secondary CNS vasculitis, but in primary, it usually is not. And the vasculitis screen, like the ANCAs, ANA, ENA, they should be negative in primary CNS vasculitis. So just to go over inflammatory markers in stroke, because when a patient presents with stroke, there could be elevated inflammatory markers just because of the stroke, just because of the immune response that starts locally in the occluded vessels, and they could generate a systemic response. So we need to remember that CRP could be elevated from day one in stroke, but they shouldn't be too elevated. Like, say it's 80, then it can't be due to stroke. And also ESR similarly would not be raised day one, unlike CRP, but ESR can elevate around 5 to 7 days and may remain elevated until about 3 months. So these are some things you can use to see, okay, what fits CNS vasculitis, what doesn't fit CNS vasculitis. And then anyone with a question of CNS vasculitis, you have to have CSF studies. Without CSF studies, you wouldn't know what you're treating. So never start treatment without CSF studies, unless you have a biopsy without CSF studies. So CSF analysis is abnormal in about 80 to 90%, but the caveat is therefore it could be normal in 10 to 20%. Again, like the ESR CRP, if CSF analysis is normal, you have to rethink of your diagnosis. Completely normal, no cells, no protein, nothing, or oligoclonal bands, then you have to rethink your diagnosis. So usual pattern is there is no cells, but aseptic meningitis pattern is highly suggestive of CNS vasculitis. So they could have a little lymphocytic pleocytosis, and it should be less than 50 cells. Usually, could go up to 100, but if the cells are like 500,000, then again, you have to question, is this really CNS vasculitis? And always normal glucose. elevated protein up to 1.5 grams per liter is normal, and it could be a very mild elevation to just above the normal, and doesn't really have a cutoff for this elevation. And occasionally oligoclonal bands and elevated IgG. So oligoclonal bands, like unmatched oligoclonal bands, would indicate in CNS inflammation when you're comparing CSF oligoclonal bands to serum oligoclonal bands. If it is unmatched, there's no bands in the serum, then you know there's inflammation going on in the brain, but it just tells you inflammation. So if the only finding is oligoclonal bands, you again question, like, could this be demyelination like multiple sclerosis, or it could be vasculitis? But like, this is where you have to put all information you have together. And so CSF changes unfortunately happen in acute stroke too. So it's really, when a patient presents with stroke, it's not really helpful for us but there's a little bit of changes that we can use to determine. So protein again can be elevated up to 1 gram, but above that, like, very unusual. There has been patients that even 1.72 gram elevation just purely because of the stroke has happened. And again, normal glucose, and 90% of patients should not have like CSF pleocytosis. They can have a little bit of cells just because of the stroke, but that should be like 10, 15, not about that. Like, if you have about that, that's indicating something else. Okay, so what are the MRI features? Unfortunately, MRI is also like, there are things we can put together, but they're not characteristics, but it's very unlikely if the question is CNS vasculitis and the MRI is completely normal, just like some white matter hyperintensities periventricularly, then that's very, very unlikely. So they could have cortical and subcortical infarcts, and most common, these are the most common features, and usually multiple and bilateral. And they, you should do a SWI like sequence, which is looking for like any microhemorrhages. And usually with small vessel CNS vasculitis, you see at least a few microhemorrhages that would make you think more towards small vessel vasculitis. And you might see parenchymal and leptomeningeal enhancement, especially with small vessels CNS vasculitis. So you always have to, if you're suspecting, you have to ask for an MRI stroke protocol with contrast, that so that they will look for this, and then they can present with intracranial hemorrhage, either ICH like in or subarachnoid hemorrhage, and they can also present with tumor-like mass lesions. In this case, like, they are very these are GAD enhancing, renin enhancing, so you would think either abscess or tumor, but these could be a presentation of CNS vasculitis. What are the angiographic features? So the reason we get most of the referrals are, one is MRI has these white matter changes, or the angiogram have some narrowing. So stenosis with normal or dilated intervening segment like this would be highly characteristic. Unfortunately, we rarely see this characteristic picture of angiogram. They're usually like mixed with atherosclerosis and like mild narrowing, and in distal vessels, very hard to determine whether it's actually narrowing. And however, if it happens, it has usually happened in multiple arteries. If it is only on one artery, very unlikely to be CNS vasculitis. And both large and small arteries could be affected. And sensitivity, unfortunately, with CT angiogram is about 40 to 90%. This is because there's two clinical subsets. We'll talk about that. Like, one affects medium and large arteries, and the other affects small arteries. So you might not capture something that's affecting, say, small arteries in a CT angiogram. Specificity is only about 30%. This is why, like, this could mimic, we'll go over differential, like this could mimic many other things. Okay, and one of the things that we've been using more and more is MRI with vessel wall imaging. Ideally, the vessel wall imaging has to be 3T MRIs with vessel wall imaging. Unfortunately, at Hamilton General, we only have a 1.5 Tesla MRI. However, our neuroradiologists have been have developed a very good protocol to look at these blood vessels. So we can get it done, but not ideal. There's lots of artifacts that goes through. So you have to know those caveats when you are reading the reports of this one, like done with the 1.5T MRI. And what you would see is you see like you can see the blood vessel here in a non-contrast, but it would enhance nicely around the whole vessel if it is like inflammation in the vessel. Again, it would only tell you there's inflammation or like cell invasion, but however, it wouldn't tell you why the inflammation happens. In the one of the caveats is in the vertebral artery and ICA, terminal ICA, internal carotid artery, you could have this kind of enhancement just because of the vasa vasorum. So that's not an indication that there's inflammation going on. And then most of the time, the differential we have is atherosclerosis causing this narrowing, but at those points, it is a little easy with this, like there would be eccentric enhancement. In here, you see that on the top part is a little, you can see the plaque, and here too, you can see the plaque. They are not around the vessel. So that might be a way that you can determine it from atherosclerosis, but other vasculopathies and dissection, you might not be able to determine. So imaging, laboratory, everything's like pointing us towards this, but we don't have a really good sense of what's going on. Is biopsy the answer? Sensitivity, unfortunately, biopsy is only about 75%. However, if you do targeted biopsies, meaning like you do an MRI vessel wall or like MRI with GAD, and then you see an area of abnormality and you target that area, and if you do that, then the sensitivity is up to about 90%. And what is important is once you think it's CNS vasculitis, you do the biopsy, 30 to 50% of biopsy reveals another diagnosis. And we've had multiple other things come up in our clinic, like especially like things like lymphoma, gliomas, and we've been able to diagnose. And you shouldn't be too worried about doing biopsies. Like it is concerning, it's a brain biopsy. However, the rate of complications are much like lower than we think. It's about 3% rate of a major complication happening. And these patients would go on like immunosuppressants for like sometimes for life. So you have to balance that risk and benefit. And in the biopsy, you will see like intramural inflammation. If it is perivascular inflammation like this, that's not CNS vasculitis, that's something else. And one thing is, if it is not a targeted biopsy, a single isolated negative biopsy does not exclude CNS vasculitis. If you have a high suspicion, you might have to do another biopsy. There's one patient we did 2 biopsies and to make sure it's not CNS vasculitis. And so we had Dr. Vaughn that we collaborate with from neurosurgery, who's been very good at doing these biopsies for us. So to just recap, primary CNS vasculitis have 2 clinical subsets. One is the lymphocytic or small vessel vasculitis, which usually presents acutely, and they would have greatly raised CSF protein because it's small vessels and leptomeningeal vessels that involved, and meningeal and parenchymal enhancement on a contrast MRI would be seen, and abnormalities can be found in biopsy, and they respond favorably to treatment. And then the second subtype is large to medium vessel, which is known as angiographically defined CNS vasculitis, and they would have abnormal vessel, and they can have their CSF should be abnormal, but a normal CSF in 10% could occur, and they would have a normal biopsy just because they're deep arteries and the biopsies are mainly in the periphery. Like medium to large vessels are involved, and you have to rule out other vasculitides in this case. And signs of inflammatory brain changes should be present. They cannot have a normal CSF and normal MRI, and we would not call them CNS vasculitis. Then it's a different diagnosis. Okay, over to you, Kim.
All right, so we'll talk about the workup of query primary meningitis of the CNS and then get into some therapies. So when we typically suspect it, or the sort of subtypes where in the literature they talk about suspecting it, is if you've got cerebral ischemic episodes. We've got evidence of strokes in different vascular beds, especially separated by time, and then especially in the presence of the inflammatory changes in the CSF, like Dr. Perera outlined. If you've got a young patient with lack of traditional cerebrovascular risk factor for stroke, chronic meningitis because of the leptomeningeal involvement in some of the evidence of PACNS without any other underlying features to explain that. Subacute or chronic headache associated with cognitive dysfunction, especially with a history of aseptic meningitis, is highly suggestive. And then if you've got unexplained both focal and diffuse neurologic dysfunction, so there's multiple different areas involved. Those are all times when your sort of spidey sense should be, increased, that this might not just be a garden variety atherosclerotic stroke. There have been some proposed criteria for consideration of suspicion of CNS vasculitis. You can see here that, and this is from a paper from 2020, where there's been a proposal for clinical features, looking at essentially a lot of the elements that we've discussed, and neuroradiological features. And so if, and then, they talk about having one clinical criteria and major or minor and one major neuroradiological feature, or two clinical features and one minor neuroradiological feature. So if this is helpful for people to kind of frame it, then this would be one way to look at it. So when we get these rule out CNS vasculitis consults, which on the rheumatology and patient service, we get a couple of them a week, and the stroke service, of course, obviously that would be the ones to generally send those to us, correspondingly would be seeing these fairly commonly as well. And they would come under internal medicine, certainly as well with these complicated patients a lot of the time. So how we look at this is sort of my thought process. So this takes the differential that I sort of spoke about before, but just sort of operationalizes it into a bit of a step-by-step way to think about it. So in terms of a possible CNS vasculitis, the very first thing we look at is ruling out infection. And again, things the residents get tired of hearing me say is the rheumatology inpatient service is really like, what do? We rule out infection, and then if it's not infection, we give them steroid. It's a little bit more complicated than that, but like ruling out infection is paramount because that's what we're going to make worse if we miss it and give them immune suppression for the most part. So really that's where we get we usually get a fairly extensive panel of viruses, bacteria, and fungi on the CSF studies. And I sometimes hear people say, they look so well, how could they possibly have an infection? But as somebody who has seen these patients, they can look very well and still have a relatively insidious infection in the CSF. And don't forget endocarditis, because again, that's one of those like ones with immune phenomenon, and often they're sort of sick otherwise. So they'd be somebody who you might be thinking about infection, but as probably we've all experienced at one point, endocarditis can really be subtle. And so really consider that in these patients. Often we're doing an echo anyway because they've had a stroke, but still think about that in terms of the infectious workup. And then ruling out malignancy, looking for malignancy in other places. Diagnosis of a lymphoma can be potentially easier done by biopsying a peripheral lymph node than by a brain biopsy, right? But some of them are localized to the CSF. And so looking at cytology, remembering that you need a large volume to rule out lymphoma. And I learned from Dr. Perera, I've learned a lot of things from Dr. Perera. And one of them is that to rule it out on CSF studies, you actually need 3 large volume, which is like 3 times 20 cc's of CSF to make sure you have appropriate cytology. So most of the time we're not getting that. So CNS lymphoma is often not ruled out even with normal cytology on your CSF. So just be aware of that. And that's again where a brain biopsy can come in. And then we go into the other categories of things. The intracranial atherosclerosis is actually one that can be very tricky, especially in the older people. And so a lot of that is based on the imaging, and we have done brain biopsies to distinguish those entities. RCVS is kind of the easiest one because they really should have that like relatively acute thunderclap headache, kind of acute presentation. And very often we can pick that up on history and be fairly comfortable that we're not dealing with CNS vasculitis. And then we hold tight, we don't give them steroid, and we do, some imaging repeat to make sure that things are slowly improving. Looking at metabolic systemic conditions, you know, some of those more atypical things, considering those for all patients. The ones, again, that the rheumatologists are comfortable with is looking for rheumatology diseases, other places, connective tissue disease, other vasculitis, antiphospholipid syndrome. Again, another one that can give you lots of strokes and be the first presentation. And then there's the primary neurological disorders, which is where I look and smile nicely at Dr. Perera, because we've diagnosed some of these patients with CADASIL or, you know, other, you know, unusual genetic things, which as a rheumatologist, I wouldn't even begin to be able to start there. And remember the vascular disorders as well, things like fibromuscular dysplasia, again, which again, the neurologists are very good at, and the neuroradiologist at you know, kind of looking at these from a vessel perspective, but those can still be very tricky in terms of like whether this is a vasculopathy rather than a vasculitis. And then autoimmune encephalitis can also mimic, though is often sort of more global and less stroke-like and more inflammatory changes. So those are all the things that you look at, and then you work through them. And so in the next slide, for all of them, for the vast majority of them, we're looking at the LP, we're doing the oligoclonal bands and the IgG index, looking for that evidence of high immunoglobulins in the CSF, protein, glucose, and cell count, as Dr. Perera talked about, and then the imaging that we talked about. Phoning a friend, we don't do these in isolation. That's why Dr. Perera and I do this together, because together we have the full differential. Separately, we're a little gray on some of the differentials, right? And then biopsy accessible tissue if possible. And as we said, we do this not uncommonly. And then hopefully with all that information together, you can come to a diagnosis. All right, so next slide. So this is I send this to the residents because I'm like, these are all the things we need to think about. Please send these studies. And this doesn't you know, cover all of it, and there's caveats to all of this, but these are all the things that when I'm going through, I make sure that I'm glancing through and I'm thinking of these in my differential. Next slide. So now we'll get into treatment. So once we're fairly convinced that there is primary meningitis of the CNS, then we are looking at how to treat these patients. And remember that this is one of the reasons why it's not just a like, oh, let's give them steroid and see if they get better. If we're talking about primary meningitis of the CNS, we're kind of committing them to, you know, almost a year-long course of cyclophosphamide with high-dose steroid on a slow taper and usually immunomodulatory therapy. And we sort of think of this as being at least kind of 2 to 5 years. And even like Dr. Perera said, some of the, you know, we often need to treat these patients lifelong. So it's not as simple as just like, oh, let's just give them steroid and see. It's really like, no, like, are we immune suppressing them for years with fairly, you know, medications with a sizable toxicity or not? Because if it's ICAD, then, you know, they need vascular risk factor monitoring. So it's a very different therapy. So all data here is case series. The conventional wisdom is that corticosteroids will generally cause remission of symptoms, but a lot of them relapse on the taper if it's used in isolation. So there was a recent meta-analysis of the therapies in PACNS that mostly look at there's two main registries. There's the Mayo Clinic registry for PACNS, and then there's the French cohort, so-called, from France that looked at that has fairly sizable cohorts in this. And then so there's sort of the induction and then the maintenance of remission side. And so for induction therapy, most patients receive cyclophosphamide and steroid. That's the most common thing in the literature. That would be sort of the standard. There's other less commonly used medications, azathioprine, mycophenolate, mofetil, methotrexate, and we do use these instead of cyclophosphamide. You know, people are doing pretty well, and there's no, like, we've done every investigation we can, and there's still no clear differentiation. They're doing well. You know, there's risk of toxicities with cyclophosphamide. Every once in a while, we'll use something like mycophenolate in those patients, and then just follow them very closely and see how they do. Rituximab is sometimes used for induction, especially for people, you know, for fertility considerations or things like that, but is definitely sort of the second line because there's much less data on rituximab's efficacy. But that being said, most of the patients in the literature who failed cyclophosphamide and truly have PACNS respond to rituximab. If people have failed both cyclophosphamide and rituximab, you probably have the wrong diagnosis. It probably is not primary meningitis of the CNS. And the patients that we've seen where they came to us with that history ended up having something else like lymphoma to account for their symptoms. So they should respond to one of those two therapies. For maintenance agents, we use all of our classic kind of immunomodulatory rheumatological medications, azathioprine, mycophenolate, mofetil, methotrexate. Again, all small comparative studies. So the Mayo Clinic cohort is about 163 patients. Their last publication on the whole cohort was 2015, and they saw a favorable initial response in 85% treated with prednisone and prednisone alone, and 80% treated with prednisone and cyclophosphamide alone. So both therapies, and there's probably a selection bias here, right? The worse off people probably got cyclophosphamide, so there's probably some selection there. So most people will do okay initially, even with even with just steroid, but then the treatment with prednisone alone, more frequent relapses. So you do really sort of need that cyclophosphamide to prevent relatively short-term relapse. And then so thinking about the poor prognostic factors, those people with large vessel involvement, if they don't have leptomeningeal enhancement, which probably means a bit of more delayed diagnosis because leptomeningeals are symptomatic, so they get seen sooner, older age, and then associated infarct rather than simply more so inflammatory lesions. Those are the patients with a poorer prognosis, and you definitely want to consider cyclophosphamide in those patients. So like I said, we do it in pretty well everybody, unless there's another compelling reason not to. And so in terms of what doses we use, we often use methylprednisolone 1,000 milligrams times 3 days if they're doing poorly or quite acute. If they're more sort of indolent, then we just use high dose steroid. We usually max at 60 milligrams per day, 1 milligram per kilogram. For the IV cyclophosphamide, the differing regimens have been used in the literature. We locally use what we use for vasculitis typically, which is sort of the PEXI-VAS protocol of 15 milligrams per kilogram to a max of 1,200 milligrams per IV infusion. It's adjusted for age and renal function, and there's a lot of tables about this in the vasculitis literature. And we do that Q2 weeks times 3 doses, and then Q3 weeks to complete a total of 10 doses. But there are monthly regimens, as you see there, that are often used in the literature. And oral cyclophosphamide used to be used very frequently, and though we don't use it as much anymore for toxicity reasons. And then the other drugs, you can do rituximab either as 2 1-gram infusions separated by 14 days, or the vasculitis dosing of 375 milligrams per meter squared weekly for 4 weeks, which is what we usually do. And then there's AZA, methotrexate, or mycophenolate, sort of at standard doses for maintenance of remission. So in maintenance therapy, in the French cohort looked at maintenance therapy, and really they found that the people had better outcomes if they received maintenance therapy with fewer relapses than those who just had their sort of induction therapy regimen and were tapered off and were sort of and then were just followed. So better, good outcomes for additional immune suppression therapy, less relapse. And maintenance therapy was the only independent predictor of a good outcome in their multivariate analysis on their close to 100 patients in this cohort. How long do we treat for? Who knows? We don't know. We'd say we treat for at least 2 years. And then consider discontinuing therapy. I would say our standard is to do 2 years, is to do 1 to 2 years with steroid at a tapering dose. We sort of do our cyclophosphamide, and we complete the cyclophosphamide, switch them to a maintenance agent. And then we are doing at least 1 year on steroid, and often, kind of 2 years on low dose steroid. And if they're doing well, then we would stop them there on the steroid and continue their maintenance immunomodulatory agent for at least 5 years. And then we would see how we do. And we've had patients who flared after 5 years, even when we stopped their immunomodulatory agent with like eGPA and things like that. So other ones. But in PACNS, it really is hard to know how long to treat for. And so it's really a risk-benefit discussion with the patient. And then, of course, remembering the prophylactic therapies against osteoporosis and Septra for PJP prophylaxis and all that kind of stuff, which is all stuff we have to think about too. And then in terms of disease monitoring, we do serial MRIs or MRA, often kind of 4 to 6 weeks after start of treatment, and then every 3 to 4 months during the first year of treatment, again, depending on how soon we can get our MRIs. If they're worsening, then it's okay, what's going on? Is it radiographic worsening? Is it worsening symptoms? Are the symptoms are the symptoms actually true inflammation? Or are they failing treatment? Is it the wrong diagnosis? So then we often repeat CSF studies, and if they're really doing poorly and they didn't have a biopsy initially, then that's where you biopsy and make sure you've got the right diagnosis.
Okay, so we'll get back to our cases and then we'll take any questions. So what happened with our first patient, the 66-year-old with hypertension, dyslipidemia, and diabetes, who presented with balance issues for 1 month, and all lab work was normal. CSF showed a protein of 1.1, glucose was normal, no cells. And as I mentioned, like CSF protein can be up just because of the stroke or any other condition too. And CTA showed diffuse vessel involvement. He went for a right frontal dural and brain biopsy after a conventional angiogram, and there was abnormalities on those vessels in the right frontal area. And the biopsy just showed senile plaques of varying type throughout the cortex, and vessels did not have beta amyloid angiopathy because they were looking for, so there's another condition called ABRA, amyloid-related angiitis, but then again, it's a vasculitis, but you should see inflammation of the vessel wall in that condition. So he just had amyloid plaque, which most of the people will have as they age, and but no angiopathy. So we were confident this was not CNS vasculitis. However, when we say it's not CNS vasculitis, when they have these features, we make sure we follow them up at least for 3 to 5 years, just to make sure we are not missing something. And we might do like every 18 months to 24 months MRIs to make sure the MRIs are not changing dramatically. And the case 2, the 27-year-old with multiple episodes of neurological deficits, peripheral blood work showed no abnormalities, CSF protein and glucose was normal, and oligoclonal bands was the only thing that was abnormal. It was unmatched in bands, indicating there's CNS inflammation, and the cells, he had 9 cells. CTA was completely normal. He went for a biopsy on the left frontal area where there was abnormality, and he had inflammation, intramural inflammation, and wall destruction. He also had focus scattered EBV positive cells. However, EBV for PCR was negative. So this EBV positivity only indicates just a remote infection, not active infection. So we were, he's young, and as Kim talked about, like rather than putting him through cyclophosphamide, we decided to put him on rituximab, and he's done well. He's about 2 years of treatment now. And then the last patient, who is a 56-year-old who had a 30-pack year smoking history, who presented with sudden onset memory difficulties and mild headaches. Again, peripheral blood work is normal, and CSF protein was very high, 1.34, IgG was high. However, no oligoclonal bands, slight cells, again about 9 in his case too. And he went for a right frontal biopsy, brain biopsy, including leptomeninges, and there was perivascular. So we talked about just perivascular inflammation would not indicate CNS vasculitis, but he also had transmural inflammation and in the leptomeningeal vessels. And so this was diagnostic of leptomeningeal vasculitis consistent with PACNS. And he was started on prednisone and cyclophosphamide. He's someone who we really valued having the biopsy in the first place, because he worsened 2 years later when we were coming off the medication, like when he was on a maintenance therapy. And how we kind of tried to diagnose this was repeat a CSF to make sure there's no, they could have infection, right? They worsen, they could have something else. They could have a stroke for another reason. They are vascular risk factors, like they have accelerated atherosclerosis too because of CNS, because of the vasculitis. So after that, he went on another induction therapy, and then he's stable now. Okay, so just some take-home points. Primary CNS vasculitis is a therapeutic challenge. We're not talking about secondary CNS vasculitis. That's a different entity. We don't need biopsies in that case. Most of the time, we don't do biopsies for secondary CNS vasculitis because we have other organ involvement, and we know, we just have to make sure is this brain involvement from that vasculitis, and there is no characteristic presentation. And diagnosis requires a high degree of suspicion and knowledge of other diseases that can mimic primary CNS vasculitis. This is where I love working with Kim, because I only know part of I always say anything on the brain I know, but anything beyond here, I would not know. So working together really helps making this diagnosis. And targeted brain biopsy establishes diagnosis. And so please, if you have suspicion, it's much better to do a biopsy than not to do one. And primary CNS vasculitis is best approached by an organized team with expertise in neurovascular disease, immunology or rheumatology, neuroradiology, and neuropathology. I just wanted to give a shout out to the McMaster Primary CNS Vasculitis Research Group. We've had, we have Dr. Ryan Rebello, David Lee, who is our neuroradiologist involved and who's helping us get these scans, and Dr. Gloria Mack, a PGY5 in neurology, and Dr. Mats Janek, who's a fellow in rheumatology. All right, thank you. And we'll take any questions. I see some questions on the chat already.
Thank you so much, Dr. Legault and Dr. Perera. This is fantastic. Yeah, sure. We have some questions, and people who would like to bring their questions in person, please, or not in person, share in with voice, and I'll bring you in while we try to answer the first question. Probably Dr. Perera about the biopsy.
So the brain biopsy, I would say we do more brain biopsies than not to make the diagnosis of primary CNS vasculitis. As I said, most of the patients I will, other than like very characteristic angiographic features, CSF features, we've treated like 1 or 2 without biopsy, but most of the time we do get it. And then the times we haven't got it, we regret it because when they relapse, we don't know what's happening. And there's like one patient that right now we are considering doing a biopsy. That patient is actually a secondary CNS vasculitis, but not responding to treatment as we would expect, and all these constitutional symptoms. So I would say 90 to 95% we do biopsies. And again, like this will be a very selected number of patients that goes for biopsy, because not all does this patient have CNS vasculitis would get a biopsy right off the bat. It's very selected. We do that thought process, rule out most of the patients, and then when we are really think, okay, it could be, but we want to confirm it, that's when we go for biopsy.
The second part of the question, Sasha, is around, any not specific, but any characteristic physical findings.
Not really. They can actually present with Parkinsonism if they are like basal ganglia is involved. They can have that type of a slowly worsening picture, and they can have other focal findings. Like if they, depending on where the lesion is, they can have like spasticity, clonus on one side. Like those could be features depending on the lesion. So there's nothing that you can pinpoint. Vasculitis can present in any way. They can be just a headache or cognitive changes or like physical features.
You did mention that, biopsy comes with 3% risk, yet it's, overall safe, in my experience with inpatient brain biopsies, the outcomes usually, because the patient is not doing great, may not end up being great. And I've seen worse than 3% outcomes. But in an outpatient setting on this patient population, that's probably much stable. What complication you've seen in your patient population?
So like we have been very lucky so far. Like for our patients, we haven't actually seen complications so far. Like I want to say, but again, for other patients, I agree. Like there's lots of, they can have complications. This is where even neurosurgeons might be a little reluctant to do biopsy, right? We don't take the decision to send for biopsy lightly. We talk with discuss with everyone, and radiology and neuro surgery when we are making the biopsy decision. And if it is futile, like if the neurosurgeon say like, look, there's nothing involved here, I think it's low yield, and we would not go there, right? Like, so it's a very decision that we take not so lightly, but and so far we haven't had complications, so we're hoping that it'll continue like that.
Fantastic. Doctor, yeah, go ahead.
No, I was going to say, once you have a complication, it's very hard to get. I have people from Sunnybrook telling me like they got a biopsy last year after 10 years because of one bad complication. The neurosurgeons were reluctant to go ahead for this kind of thing. But then what you have to remember is like the medication would have side effects and complications, lifelong complications too. So that's where you weigh the benefit and benefit for that.
Thank you. Dr. Holbrook, please go ahead.
Thanks very much. That was a very nice review. And I wondered if you could, this is a relatively small part, but if you could help me clear up a controversy. In clinical pharmacology, we would actually say that stimulant-induced vasculitis, including cocaine, is reportable. It does not exist. There's no good evidence that it exists. And the cocaine-associated vasculitis is actually levamisole adulteration. And if you had an actual proven vasculitis with a stimulant, you'd be looking for other causes. I just wondered in your literature whether there really is any good evidence. You know, obviously the stimulants are heavily associated with stroke, but is there any good evidence that the stimulant part itself does cause an actual vasculitis?
I don't think there's a good evidence of that, no. And I'd say most of the stimulant associated quote unquote vasculitis that we see is probably RCVS, right? It's probably reversible cerebral vasoconstriction syndrome. The trouble with that entity is that it was really only relatively recently described. So a lot of the old literature in this mixes all of these things together in a heterogeneous bag that is probably separate. So I totally agree with you, and I wasn't precise in my discussion there, but I agree that the actual true vasculitis affecting the brain, which can happen in exactly levamisole associated, similar to how we can see renal involvement that is inflammatory, would be the levamisole associated, and cocaine itself would be the vasospastic component in RCVS. Probably. Again, everything in this literature is all like probably, but that would probably be the distinction.
Fantastic, thank you. This question from Dr. Gernstein relates to what exactly the definition of a small vessel in this situation, and which part of the vessel is really this is targeting in terms of inflammation. Is the endothelium, intima, media, which part?
So in the brain, we call the ICA, MCA, like the proximal branches, like M1 and M2 as medium vessel, and vertebral artery basilar would be medium vessel. So it would be posterior cerebral artery, but anything beyond in the periphery, like even the branches, like smaller branches of the MCA, like M3, M4, and distally, so arterioles, venules, those would be small vessel. And it's usually intima and media, but endothelium involvement can happen too. Like where we see most is media involvement, and that's what we look for.
Fantastic. It's a question from Dr. Harper about the future of first-line therapy, whether it be targeted therapy rather than toxic therapy, like what we're seeing in oncology. Thoughts around that in terms of which primary and which is secondary? I mean, treatment.
In terms of, first-line therapies, less toxic therapies. I mean, I think that's what we're striving for that in rheumatology in general. I think half of our game is finding things to replace cyclophosphamide, which has worked so well for our patients, but has, especially in the past with higher doses, been associated with significant toxicities. There's probably going to be very little evidence generated primarily in the PACNS literature because it's so rare. And what we will likely end up doing, which is what we've done so far, is borrow drugs from other conditions. ANCA-associated vasculitis is so much more common. Most of our drugs are probably in future going to be borrowed from that. I mean, you can see that we could imagine that we'd start using things sort of off-label, and that's all off-label, but borrowed from the on-label ANCA vasculitis drugs. So there are, new ANCA vasculitis drugs kind of coming down the pike, and I think we will see a broader uptake. I think we'll see more. The more data that comes out about rituximab, the more we'll probably be more comfortable using it. Relatively safe drug, particularly compared to cyclophosphamide. So I do think we'll see a shift. I don't know how much primary data in CNS vasculitis, in primary angiitis, unless we can like really get our act together and globally and then make these huge studies. But I think we will likely see better drugs in future from the other indications.
That's, I have Dr. Panju, who has his hands up. Akbar, if you want to go ahead. Okay, until we get Akbar, if he wants to. The couple of questions.
Well, thank you very much for an excellent presentation. Now, you mentioned that the primary vasculitis is very rare, and secondary vasculitis of the brain is more common. I mean, at what stage do we call a primary vasculitis when everything else is negative, like autoimmune work and everything is negative? At what stage do we call it a primary? And also, what's the prognosis for primary versus secondary vasculitis? Similar?
So we call it primary when there is no evidence of any systemic involvement. So where essentially all the rest of our workup is negative and the patient has vasculitis in their brain that we're fairly convinced of from biopsy or like we talked about in the caveats angiography. So that's when we call it primary angiitis. And in terms of the prognosis, it's got a relatively good prognosis in terms of survival, about 5% mortality, which is compared to some of our other vasculitis is a little bit lower. The morbidity can, of course, be the main issue. And from a good outcome perspective, there can still be, a good 25% of people can have a poor outcome from a functional perspective from their stroke. But the secondary CNS vasculitis, it really depends on what that secondary CNS vasculitis is. If it's vasculitis secondary to a CNS lymphoma that we then find, then that can have a very poor prognosis. They tend to unfortunately not do well. Whereas if it's secondary to an infection, you treat the infection and it never comes back. They never have anything else. So it's very dependent on what the underlying secondary cause of the vasculitis is.
Thank you. That's great. There are many excellent questions. However, we are at time, and I'm sure that everyone who would like to bring up a question with Dr. Legault or Dr. Perera can reach them easily around here, or you can stop by the board's clinic and chit chat with them. What day is your clinic there? What was Tuesday? No.
It's Monday.
Monday.
We only have once a month clinic, but recently we were able to do a full day clinic so that because we do get lots of referrals. And there's a question asking about headaches and some changes in MRI. Is this vasculitis? Like, I just want to say, please do for a 25, 30-year-old, like 1 to 2 spots with headaches could be normal, but anything above that should be abnormal. They should get at least a CTA and maybe CSF studies.
Thank you for answering that question. And thank you very much. It's been a fantastic presentation, very important topic. I've learned so much today and lots of good discussion. So thank you again, and wish everyone a good rest of your day. Have a good day.